be teaching you today about autonomic nervous system, everything basically that you need to know about. So first of all, let me share my screen. I hope you can see it right now. And can you see my screen right now? Excellent. Good. So let's do this. Okay. So we are going to speak about autonomic drugs. For the sake of understanding autonomic drugs, we must understand what does it mean autonomic. Well, it's all about our nervous system. Our nervous system is subdivided into two portions, voluntary and non-voluntary. Okay? So the voluntary one, it's your, the stuff that we have some type of control over it. And it is subdivided into your basically CNS, and which is central nervous system, and BNS, which is peripheral nervous system. The CNS is made up of the brain and the spinal cord, while the BNS is made out of the spinal nerves and the cranial nerves. Okay, what about the one that we have no control over it? The non-voluntary type of thing, involuntary nervous system. The involuntary nervous system, it is basically called also the autonomic nervous system. For example, we cannot control our heart rate. We cannot control our blood pressure. All of these we consider it to be autonomic, which means we have zero control over. Okay, so we have the sympathetic and parasympathetic. Some people like to think like, oh, sympathetic stimulates, parasympathetic inhibits. It's not totally true, because it depends on which organ are we speaking about. So the better way to think about it, if you are running from a lion, okay, you need your sympathetic nervous system. If you are resting and digesting after you ran from the lion, you went back home to a safe place and you just want to eat your lunch or dinner and you just want to lay and sleep and rest. This is parasympathetic nervous system. Okay, the lion is going to attack. What is going to happen to me? Sweaty, 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 to cool myself. Also, what else? Tachycardia, hypertension. Why? Well, basically, my smooth muscles has been contracted. What else will happen to me? I said contractility and hypertension. Okay, good. What about my pupils? Mydriasis. Mydriasis is when the pupils are big, okay? And why they are big? Because I'm running away from the lion. I need to see where I'm going, okay? What else? Well, I have vasoconstriction of the vessels of my intestine, which prevents the blood from going to my intestine. What do you mean that we can, our autonomic nervous system can decide which organ gets the perfusion? The answer is yes. Well, so which organ should get the perfusion when I'm running away from the lion? The answer is the muscles. So the muscles should take it, and the heart. Okay, I ran away from the lion. I'm resting, I sat back home, and all is good. What should happen now? Parasympathetic need to be activated. Well, parasympathetic is rest and digest. It's known as rest and digest. So it's good for resting. Okay, so I will eat. Eat? Yes, I'm resting. So when you eat, this is peristalsis going to be activated, which is the movement of the intestine. This is parasympathetic. Also, your heart rate is going to go down. Your blood pressure is going to go down. Everything is going to go down. Why? Because you are just resting now. You are done with the lion, basically. Okay, sounds good. What else? Well, we are resting as well. So our pupil size, do they need to be big or small if we are resting? When we are resting, our pupil size is normally really small. Exactly. We don't need the light anymore. We are totally relaxed. Okay? So also the blood will be more in the visceral organs and not in the muscles. Okay, good. So they write here autonomic and somatic. Somatic is the stuff that we have control over, such as voluntary motor nerves, cranial nerves, and not all of them, only the motor ones, and also spinal nerve. So voluntary motor nerve, it's acetylcholine mediated, and yeah, it binds to the NM type of receptor. And you must know one thing actually about this. There is a disease in which we have formation of antibodies against the NM. Do you know which disease is it? Antibody against the NM receptor. Well, the disease is myasthenia gravis. Myasthenia gravis. Okay, so neuromuscular junction is going to, when it works, it's going to work on the nicotinic channel, which is this one. And if someone asks you what is nicotinic channel, please tell him that it's an ion channel, which means if this is the postsynaptic cleft, and this is a nicotinic channel. Nicotinic channel is just a sodium ion channel that propagates sodium to the postsynaptic cleft, which activate action potential. So the other ones, such as parasympathetic and sympathetic. Before we speak about these, I must tell you a little bit about the autonomic nervous system anatomy. So you are like, okay, you said some of it stimulates, some of it inhibits, some of it dilates, some of it constricts, some of it lead to vasodilatation, some of it lead to vasoconstriction, some of it lead to contractility, some of it lead to decreased contractility, tachycardia, bradycardia, bronchoconstriction, bronchodilation. But where it is located, what is this mysterious, where is the mysterious nerve located? That give all of that. For the sake of your simile, you actually don't have to know a lot about it. I'm going to tell you the bare minimum that you have to know. So, if I'm going to give an example for each one because that makes it much easier. So, let me give you the example. Okay. Notice. Or even better, vagus. Vagus is the prototype, you know. Vagus is a cranial nerve number 10, and it comes originally from the medulla oblongata, from the brain. And yeah. Okay. Okay, so you can see here, this is the brain stem, okay? And there is multiple nerves coming from it. One of them is the vagus. And you can see vagus is coming down, and then it gives this ganglion, right? And after the ganglion, it's going to every single organ inside of the body. Well, let's take a proximal organ, which is, I don't know, something somewhere right here. Now you need to know the distance. The distance from the brainstem until the ganglia of the nerve is pretty long. So it takes them a while to reach it. After that, there is a ganglia, and really short distance after the ganglia, you will have the affected organ. Do not be tricked by vagus because it actually has many ganglia, even more distal to that. But yes, okay. So for vagus, as you can see, he has many other branches. It's not only one branch and that's it. No, he has many branches. It has many ganglia all over the body. Also, if we speak about other cranial nerve, autonomic cranial nerve, you must know that, okay, good enough. Yes. Let me see. I'm looking for an exact one, but I cannot find it. There was like one picture that, oh, okay, this one. Yes, okay, good. So as you can see here, you can see the cranial nerves, and each of them, how it attaches to one ganglia. So ciliary ganglia, sphenopalatine, submaxillary, the otic one, and the distance between the brainstem until you reach the ganglia, it's really long, see? But from the ganglia until the organ, it's really short, right? So this is something you need to know. Okay, well, which cranial nerve are considered to be parasympathetic? It's easy, 1973. So think about some holiday you have, something interesting that happens in 1973. So yeah, basically 1973, that stands to nerve 10, 9, 7, and 3. Okay. Also here we have the sympathetic. The sympathetic, for the presynaptic, they are quite short. They are called paravertebral ganglia. They are just next to the vertebra. So it's quite short. I want you to notice something. All of them, sympathetic or parasympathetic, the first ganglion are all made of what? They are having what in them? Nicotinic channel. But it's the NN, not the NM. Okay? So in the motor one, it was NM. But here, all of them has NN. Okay, so the sympathetic works. Yes, when it works, it can work in the sweaty glands, make you more sweaty. Notice, this one is a typical. Acetylcholine normally for the parasympathetic, but this is the exception. Sweaty glands. Norepinephrine, smooth muscles contraction, glands, and nerve terminals and cardiac muscles, which lead beta 1 increases the contractility. The function of the D1 receptor lead to vasodilatation of the renal vasculature, smooth muscles. Okay, what about this? This is the adrenal medulla, which produces catecholamines. So when the acetylcholine is going to stimulate the NN receptor, you are going to have plenty of catecholamines inside of your circulation, which are going to have effect on both your heart and your vessels. So, okay, you are like, well, I will take that from you. Like the parasympathetic, at least 1973 nerves, but how come they are cranial nerves? What about the rest of the body? Well, you are right. Rest of the body, it's mostly vagus, but if you go so much down, it must be something else. So this is actually a branch that comes from the S2, S3, S4, and spinal column. And this portion is going to give basically what? Parasympathetic nervous system innervation to the end of the GI tract. Splenic nerve, pelvic splenic nerve. And the cranial nerve number 3, 7, 9, and 10 are part of the parasympathetic nervous system. Adrenal medulla is directly innervated by a preganglionic sympathetic fibers. Sweaty glands are part of the sympathetic pathway, but are innervated by a cholinergic fibers. So a few things here you have to know, including the 1973 type of thing, the pelvic splenic nerve, all of these are parasympathetic, while the sympathetic ones are mainly coming from the spinal cord. Acetylcholine receptor. The acetylcholine receptor are subdivided into two families, nicotinic 1 and muscarinic 1. The acetylcholine, I imagine it that it looks like this. So this head is responsible for binding to the nicotinic channel receptor. Remember, nicotinic channel is not that simple. It's like this, but it attached to what? An ion channel, a sodium ion channel, okay? So when this attaches here, a sodium ion channel is going to be open. Also, they can bind to some muscarinic receptor, I mean the other portion, okay? So nicotinic acetylcholine receptor are ligand-gated channels allowing the efflux of potassium outside and the influx of sodium inside. So it's with the gradient. And in some cases, even calcium. Okay, so two types of nicotinic receptors or channels. We have NN, which is found in the autonomic ganglia, adrenal medulla as well, and the NM, which is only found in the neuromuscular junction or the skeletal muscle. Muscarinic acetylcholine receptor are a G protein coupled receptor that usually act through a second messenger. So what's a G protein? Let's watch a little video to understand what is G protein. So a G protein is a serpentine-like receptor in which there is this receptor that has, crosses the membrane 7 times. 1, 2, 3, 4, 5, 6, 7. Okay? So a ligand bind to the serpentine receptor, which lead to conformational change of the receptor from the inside. And that is going to lead to stimulation of the G protein. The G protein has 3 subunits, the alpha, beta, and the delta. When he gets stimulated, the G protein is going to exchange the GDB by GTB, and that is going to dissociate the alpha subunit, which is the movable subunit, and as you can see, the alpha subunit is going to bind to the target protein, which lead to downgrade effect. For example, it can increase cyclic AMP, which can lead to internal effect. So it can bind to the adenylate cyclase and create as cyclic AMP. Okay. So they write, muscarinic acetylcholine receptor are G protein coupled receptor that usually act through a second messenger. 5 subtypes, M1, 2, 3, 4, 5. Well, how to know which one has a GS, GI, or GQ, sorry. What is it? Kind of easy. Just write in front of you M, muscarinic. So see the peak? This is the first peak. So M1 is a GQ coupled. What about M2? GI coupled. What about M3? GQ coupled. What about M4? GI coupled. What about M5? GQ coupled. Okay, so it makes it easy. Okay, so M1 till 5 found in the heart, smooth muscles of brain, exocrine gland, and on the sweaty glands, but they have the only cholinergic sympathetic portion. While the muscarinic normally are in the parasympathetic. The only rare occasion is the sweaty glands, in which we have sympathetic, in which we have muscarinic receptor, but in a sympathetic pathway. Okay, let's speak about maturation control. How do we control our urination? And what can lead to a defect in it? Maturation control. Maturation center is in the pontine in the bones. In the brain, basically, remember, the brainstem consists of medulla, bones, and midbrain. So it's in the bones. It regulates involuntary bladder function via coordination of the sympathetic and the parasympathetic nervous system. Okay, so that center in the brain help us to know when to be or not to be. That is the question. So it's all controlled by the bones. So here they write a few notes. Each receptor, where it is located, what is function, and stuff like that. So let's start to think, well, if you are running right now from the lion, I'm not saying that you ran from the lion. No, you are still actively running from the lion. Should your GI tract be working? Should your urinary system be working? Exactly. So during active running, these will be stopped. So during sympathetic nervous system, which is running from the lion, you should have more urinary retention. Okay, I ran away from the lion. I just reached home. I closed the door behind me. I finally feel relieved. I look at my pants. It's full with urine. Why? Because there was activation of the parasympathetic nervous system at that moment. At the exact moment I entered the house, I felt the relief. I had a shock of parasympathetic nervous system, which made me be myself. So parasympathetic lead to increased urinary frequency and voiding. Some autonomic drugs act on the smooth muscle receptor to treat bladder dysfunction. So let's see. Here we have an external erythral sphincter, which we as human beings have total control over it. The control is mediated by the pudendal nerve, which is a branch of the iliac nerve. It's a nicotinic receptor, and it's an NM. There is no drug that works on it because we work on it. It's our job to control it. The internal erythral sphincter, however, it has an autonomic receptor on it, which is the alpha. How do I memorize which one is where? So for the USMLE, you must know the receptor in two locations in the bladder. First one, internal erythral sphincter, which is only the alpha receptor, alpha 1 receptor, and in the detrusor muscle, which is the beta 3 and the M3. So the detrusor muscle, I just imagine it's a D3 detrusor muscle. So it's the B3, M3, and the D3 muscle. Okay? Okay, so now we know where is each receptor located. What's up with this guy? So the sympathetic input comes from the hypogastric nerve, and it supplies the B3 receptor and the alpha 1 receptor. During sympathetic input, do you want to urinate or retain the urine? Retain the urine, absolutely. So the alpha 1 receptor will be constricted, right? What about the detrusor? It will be relaxed. That helps you to retain. Okay, what about the M3 receptor? This is parasympathetic input. And if it's activated, you will have contraction of the bladder. If you have an antagonist against it, you will have relaxation of the bladder. Okay, so the following drugs exist. So first drug, Muscarinic Antagonist, like oxybutynin. Oxybutynin, they work at the M3 receptor. M3 receptor is located at the detrusor muscle. Muscarinic antagonists, so they stop the effect of parasympathetic nervous system. The parasympathetic nervous system normally made us urinate. So if I'm using an antagonist, I'm stopping the urination. So why I would like to stop the urination? Because of urgency incontinence. So it's an M3 inhibitor receptor, lead to relaxation of the detrusor muscle, and thus less detrusor overactivity, thus less urgency incontinence. Okay, what about muscarinic agonist, like pithanicol? Well, that is going to contract your detrusor muscle, which is going to promote bladder emptying. We use it for urinary retention, especially post-operation. Write a note, it's post-surgery. What about the sympathetomimetic, like mirabegron? Well, it works at the beta 3 receptor, which is located also on the bladder. Binding to it, well, let's think. Sympathetic, it wants us to retain, so the detrusor must relax. So it will lead to relaxation of the detrusor smooth muscles, more bladder capacity, urgency incontinence we can use it for. Alpha 1 blocker exists in tamsulosin. Prototypical drug is tamsulosin. So we have alpha 1 receptor inhibitor, can lead to relaxation of the smooth muscle. Remember, the alpha 1 was the most external one. So yeah, it leads to relaxation of the prostate and the bladder neck, which decrease the urinary obstruction, and it can be seen in cases of benign prostatic hyperplasia. So if you use it in benign prostatic hyperplasia, you will relax the output, which allows the urine to go out. Okay, so we have the following receptors. Before I speak about these receptors, since all of them are sympathetic, I want to show you the following. Alpha, alpha, beta, beta. 1, 2, 1, 2. For the sake to know which one is coupled to which G receptor, it's easy. It's a kiss. Kiss. Q-I-S-S. So, if we speak about the alpha 1, it's GQ. Alpha 2, GI. Beta 1, beta 2, GS. Okay. For the cardiac muscle, I want you to know that mostly we have alpha 1. Minorly, we have the other ones, but these are irrelevant. It's mostly alpha 1. So if you want to stimulate the heart, I'm really sorry, it's not alpha 1, it's beta 1. If you want to stimulate the heart, it's beta 1 agonist. If you want to inhibit the heart, beta blocker, but beta 1. Skeletal muscle mostly has the beta 2, and it will be really important because we will have a relaxation of it, and that will be useful. Why? Because it's sympathetic nervous system. So when you run away from the lion, you would like more blood to go to your muscles, so you will activate your beta 2 receptor. The vascular smooth muscles, however, has alpha 1 mostly, right? Which lead to vasoconstriction, which what happens if you have this tube and you make it smaller? The flow inside of it is going to be much more faster. So the velocity is going to increase big time. Okay? And that will promote more blood reaching the muscle much more faster. Okay. Brachial smooth muscles. Mostly beta 2 receptor that are located on the bronchi, leading to bronchodilation. And that is going to help you take a deep breath. Okay? Why? Because you need more air while you are running away from the lion, right? The liver. Well, the liver can be stimulated and lead to more sugar formation after you activate the beta 2 receptor through the process of gluconeogenesis and glycogenolysis. Adipose tissue has the beta 3 on it, mostly, while the CNS basically has all of them except the B3. Do not let this trick you. The CNS also has the M1, 4, 5, and many of them, basically. The bladder, neck, and the prostate, we said the alpha 1 antagonists are used for that, and the beta 3 receptor antagonist as well. Okay, so that is for maturation control. Please do not forget that the alpha 1 is located outside, and the beta 3 and the M3 are located inside. Know the name of the nerves: pelvic nerve for parasympathetic, hypogastric nerve for the sympathetic, and pudendal nerve for the somatic, which means we do have control over it. So the last thing I want you to know before the break, that the G protein linked second messenger include the following. So you need to know that mostly it's just all about the kiss. So kiss, G-I-S-S. Cholinergic is different, but if you keep going, kiss, kiss. And dopamine is a psycho, so S-I. That's it. So all of them are kiss except dopamine. Cholinergic, we know that it's different because I gave you the M mnemonic, so it was a Q here, I down here, and a Q up here. Okay? Okay, good. So 10 minutes break, and I will see you in 10 minutes. Okay, everyone, welcome back. So let's keep going. We have the following receptor for adrenergic. We have the alpha 1, alpha 2, beta 1, beta 2, and beta 3. For each of these receptors, it has a totally different function, totally different location. If we are speaking regarding the alpha 1 receptor, the alpha 1 receptor is located mainly in the vascular smooth muscles, and since it's a GQ coupled, it's going to lead to vasoconstriction. So let me explain first of all what GQ coupled even mean. So as you can see here, the H1 receptor, which is a kiss, so it starts with a Q. So that will be H1 receptor, H1. Alpha 1 receptor, which is also a kiss receptor. V1 receptor, which is also a kiss receptor. And finally the M. And remember about the M. We take the tip Q, I, Q, right? Okay. So M1 and M3 are coupled with GQ. Anyway, so these GQ are going to activate something called phospholipase C that is going to convert BIB2 into DAG and IB3. However, you don't really need to know what these are. They are just secondary messenger that are going to increase the calcium inside of the cell, which is going to lead to smooth muscles contraction. Okay. So, they're right. Yes. So we have increased vascular smooth muscles contraction, increased pupillary dilator muscle contraction, which means mydriasis. So you will have more mydriasis, which means big eyes, dilated eyes. If you forget what is meiosis and mydriasis, remember mydriasis has a D, so it's dilatation of the eye. Also, more intestinal and the bladder sphincter muscle contraction, which means basically more going to the bathroom. But actually the contraction of the sphincter of the bladder prevent you from going to the bathroom. So we must block this receptor for the sake of going to the bathroom. Alpha 2 receptor, it's a GI. To understand the GI, we need to speak about this pathway. So let's speak about the GS, stimulate adenylate cyclase, GI, inhibit the adenylate cyclase. Adenylate cyclase normally convert ATP and make it cyclic AMP, which is going to convert to protein kinase A, which is going to lead to more calcium inside of the heart, which leads to contraction of the heart, and also can lead to inhibition of the smooth muscles. Okay? Okay. It prevents the contraction of the smooth muscles. So if I inhibit it, will there be a contraction of the smooth muscles? That's what we will see. So the alpha 2, it's a GI coupled. I means inhibitory. So it decreases sympathetic adrenergic outflow by binding to the presynaptic cleft. So by binding to the presynaptic cleft, the alpha 2 is going to inhibit the outflow of the norepinephrine and the epinephrine. Also decreases the insulin release by functioning on the pancreas. Please keep in mind that beta 2 receptor is also located on the pancreas, but that one increases the insulin release. So beta 2 increase, alpha 1 decrease, and it's easy to remember because alpha 2 decrease because it's a GI, while beta 2 increase because it's a GS, I mean insulin release. What else? Decrease in the lipolysis will occur and more platelet. So decrease in the lipolysis in case of alpha 2, increase in the lipolysis by the beta 2 and the beta 3. Why? Because both of them increase the insulin basically. More platelet aggregation and less aqueous humorous. Okay, the beta 1 is mainly located at the heart, and stimulating it lead to basically more contraction and more heart rate. So at beta 1, more heart rate, more contractility, and more renin release because we had a beta 1 receptor located at the juxtaglomerular apparatus. More renin, more RAS, more blood pressure. Also, it increases the lipolysis. In general, the beta receptors increases the lipolysis. Beta 2. Also GS, but it's located on the lungs, not in the heart. So they will lead to vasodilatation, bronchodilation, to lungs. Remember about the vasodilatation, it's actually quite important. Also, they can lead to lipolysis and increase insulin release, which was the opposite from what happened in the alpha 2. Also, they can increase the glycogenolysis, which is destruction of glycogen that is normally stored in the liver and in the kidney, and less uterine tone, which basically lead to tocolysis, which is preventing delivery or delaying the delivery. Increase aqueous humorousy production, which sucks. Why? Because it can lead to glaucoma. And if you want to prevent the glaucoma, you need to inhibit this process by beta blocker. And more cellular potassium uptake. Okay, what about the beta 3? Beta 3 increase the lipolysis because they are located at the lipocyte. Thermogenesis in the skeletal muscle also they increase, and more bladder relaxation. Why? Well, beta 3, it's a 3, the true muscle, the truther muscle. So when you stimulate it, you will have a relaxation. Remember, sympathetic, its aim is to retain the urine, not to excrete it. Cholinergic receptor is the QIQ. Remember, they are mainly parasympathetic receptor. So these parasympathetic receptor are QIQ. They mediate higher cognitive function, which means they are in the brain, and they stimulate the enteric nervous system. You are like, wait a second, what is enteric nervous system? Well, the enteric nervous system is a type of nervous system that is mainly located inside of our abdomen. And this enteric nervous system, we have zero control over it, and it's the biggest nervous tissue outside of the CNS. Okay, so that's it. Just like hundreds of neurons and nuclei and ganglia, located outside of the CNS. So they write. M2 receptor, it's a GI. It decreases heart rate, contractility of the atria. This is actually quite important. I want you to know that beta 1 receptor is located at the heart. M2 receptor is also located at the heart, but their function is vice versa. The M3 receptor, it's also a GQ, and it increases exocrine gland secretion, such as lacrimal gland, sweaty gland, salivary gland, and gastric gland. Basically, they increase the gland secretion. The secretion of the gland was mainly, at least the sweaty glands. Was it sympathetic or parasympathetic, the sweaty glands? It was sympathetic, absolutely, but it was weirdly and rarely mediated by acetylcholine, not catecholamines. By the way, cholinergic is the same as telling you like parasympathetic, okay? The M3 is a GQ coupled, increases the exocrine gland secretion. We spoke about this. Also more gut peristalsis because it's parasympathetic, more bladder contraction because it's parasympathetic, it want to get the urine out. More bronchoconstriction because you are relaxing, you are not running away from the lion, you don't need your lung. More pupillary sphincter muscle contraction, which is meiosis. It has no D, so it's getting smaller, not bigger. And yeah, basically, you don't need your pupils, so they become bigger, smaller. Ciliary muscle contraction for accommodation, and more insulin release. Also, endothelium-mediated vasodilatation. Endothelium-mediated vasodilatation. Okay, what about the next thing? Well, we have dopamine receptor. Well, dopamine was the only crazy one. Remember? It was a psi. S and an I. So dopamine is the crazy one. S and an I. So D1 is S. It relaxes the renal smooth vascular smooth muscle. You are like, wait a second. How can an GS lead to vasodilatation? Well, it always does. Look, activation of the adenylate cyclase will more cyclic A and B, which make more protein kinase A, which is going to inhibit the myosin light chain kinase, which normally lead to contraction. So you will have relaxation and vasodilatation. This was also true while we spoke about the beta 2 receptor, which led to vasodilatation. So a GS always lead to vasodilatation, not vasoconstriction. The D1 also can activate something called the direct pathway in the striatum, which is a portion of the basal ganglia. There is two structures in the basal ganglia you must know for the USMLE. They are the striatum and the lentiform nucleus. Lentiform nucleus. The striatum is made out of the caudate and the putamen, while the lentiform nucleus is made out of globus pallidus internus and externus, okay, and the No, that's it. Globus pallidus externus and internus. Okay, so what about this pathway, direct and indirect? These are type of pathway which help us to control our body. I mean, why should we flex our hand or extend our hand? All of this is mediated by these pathways. We'll speak about these pathways more when we discuss CNS. D2 receptor, it's a GI type of receptor, and it modulates the transmitter release, especially in the brain, inhibit indirect pathway of the striatum. Okay. So what about the histamine receptor? It's a kiss. So H1 and H2. When you dine with 2, right? So it's GS, it's for dining. So that is more gastric acid secretion. While the H1 receptor increase in the nasal and the bronchial mucus production and more vascular permeability, bronchoconstriction, pruritus, and pain. Basically, the H1 receptor is the type of receptor located at your mast cells, which lead to a massive amount of histamine to be released into the area, which leads to all of the bad symptoms of histamine. Okay, what about vasopressin? We have V1, V2, it's also a kiss. So the Q, it will lead to more smooth muscles contraction. Vasopressin, it presses. So that is vasoconstriction, right? And the V2 is located at the collecting tubule, the principal cells, if you remember, and it increases water permeability and reabsorption via upregulating of the aquaporin 2 in the collecting tubule of the kidney. Also releases the von Willebrand factor. Okay, nice. So what about the autonomic drugs? For the autonomic drugs, we have the following. Release of norepinephrine from the sympathetic nerve end is modulated by norepinephrine itself. What does that even mean? So when the norepinephrine gets out of the presynaptic cleft, and it's so much, it's going to bind to the alpha-2 receptor. Remember, alpha-2 receptor use the mnemonic kiss. GI, it's inhibitory. So that is going to inhibit the presynaptic cleft from secreting more norepinephrine. So that's what they mean when they say release of norepinephrine from the synaptic nerve ending is modulated by norepinephrine himself, acting on a presynaptic alpha-2 autoreceptor, which lead to negative feedback. So when you have too much norepinephrine in the synaptic cleft, it's going to decrease the release of norepinephrine. Okay, so let's speak about the life cycle of each of these hormones really quick. So the choline comes, and it's just an amino acid. It binds to the acetyl-CoA from the Krebs cycle, and now we have acetyl-CoA. The acetyl-CoA is going inside the vesicles, and then it's going to be released after calcium is inserted into the presynaptic cleft, and that is going to activate the snare protein, which is going to move the acetylcholine to the presynaptic cleft and release it. The acetylcholine is going to bind to the acetylcholine receptor and the nicotinic receptor, which leads to function. Afterward, the acetylcholine esterase, which is an enzyme, is going to destroy the acetylcholine, making choline and acetate out of it, which are going to be recycled. If we speak about the noradrenergic type of receptor, type of synapses, well, actually it comes from tyrosine. Tyrosine comes from phenylalanine, and they create DOPA. DOPA make dopamine, and that makes norepinephrine. And the insertion of dopamine or norepinephrine inside of vesicles requires something called VMAT. So after the norepinephrine is here, with the same mechanism, calcium and snare protein are activated. Norepinephrine goes to the synaptic cleft. Inside of the synaptic cleft, it can bind to its receptor, and if it was too much, it's going to do negative feedback by binding to the alpha-2 receptor, and some of it can be reuptaked by the NET. Okay, norepinephrine reuptake transporter. Okay, all of these are target to drugs. That's why I'm telling you about them. So amphetamines use the norepinephrine transporter, which is this guy, to enter the presynaptic terminal. So amphetamines use this, come in, Excellent. They are inside of the presynaptic terminal. So what will they do? Well, they will will use the VMAT, which is vesicular monoamine transporter, to enter inside of the vesicle, the neurosecretory vesicle. Okay, why would the amphetamine do that? Well, they displace the norepinephrine from the vesicle, and thus you will have more norepinephrine, which give you all of the norepinephrine symptoms, right? Once norepinephrine reaches the concentration threshold within the presynaptic terminal, the action of NAT is reversed, which means when you have so much norepinephrine here, the negative feedback will start working, which is going to inhibit the whole reuptake thing. Yes, so that's what's written here. The action of NAT is reversed and the norepinephrine will be expelled into the synaptic cleft, contributing to the effect of increased norepinephrine, which is seen in people on amphetamines. People who consume amphetamines are mostly students. Why would a student consume amphetamines? Well, it keeps them up for a really long period of time, keep them energized, they never get tired. They can study tens of hours and feel nothing. And they can become addicted to it, but that's happen later. Also, then amphetamines make them feel good about themselves. It makes them feel grandiose and like I'm great and smart. Yes. Oh, yes, ADHD, attention deficit hyperactive disorder. We do not use amphetamine for it. We use methylphenidate, which is like an amphetamine-like substance, but not really amphetamine. Amphetamine are highly addictive. Methylphenidate is much less addictive. Still, they have some addictivity. Okay, so what else work here? Cocaine also work here, inhibiting the NAT, which means more of the substance will be here. Cocaine is the same. And also ephedrine is the same. All of these drugs are leading to hypertension, dilatation of the pupils, and all of the horrible symptoms we spoke about previously. Do not forget about the snare protein and how in the cholinergic receptor, the botulinum toxin used to bind to it. Razorbeam is a really old antihypertensive medication, not used anymore. And it's not used anymore because when people use it, they had less norepinephrine, which made them really, really depressed, and they started to kill themselves. So that's why we stopped using Risperidone. Oh yeah. Okay, so let's speak about the cholinomimetic agent. Cholinomimetic agent, we have two families. First of all, I want you to know that it's like, it is a parasympathetic like drugs. So they are going to lead to, well, symptoms that are the same as parasympathetic nervous system symptoms. So they include the following. Let's take a look. Okay, watch out for exacerbation of COPD, asthma, and peptic ulcer in susceptible patient. Why? Because when you use a cholinomimetic agent, you will have a bronchoconstriction, which exacerbates COPD and asthma, and more gastric acid secretion, which lead to peptic ulcers. So we have direct agonists, which are just basically binding to the acetylcholine receptor, and an indirect agonist, which are inhibiting the acetylcholine esterase, meaning no breakdown of the acetylcholine, meaning more acetylcholine functioning on the receptor while having the same amount of acetylcholine. So direct agonists include beta-nicole, carbicol, methacholine, and pilocarpine. The beta-nicole we use it mainly for urinary retention, especially post-surgery. I mean, somebody has surgery and now he cannot pass urine. So they lead to activation of the bladder, smooth muscles, and resistant to acetylcholine esterase. Okay, so it will not be destroyed by the acetylcholine esterase. It's going to stay in the synaptic cleft, which is a good thing. It does not have a nicotinic activity, which is also a good thing. It will not lead to symptoms that you don't want it to have. So beta-nicole can just activate the bladder smooth muscles, and that's it. Meaning that we will have more urination. So after surgery, if the patient is not urinating, you can prescribe for him beta-nicole. Okay? So the next one is the Carbicol. Carbicol is carbon copy of acetylcholine, but this one is also resistant to acetylcholinesterase. Carbicol is resistant, it leads to constriction of the pupils, which make the pupil much more smaller, and it's good for open angle glaucoma. Let me explain. The glaucoma story. So inside of the ciliary body, we have formation of the aqueous humorous, which then goes inside of the posterior chamber, which is behind the iris, and then goes towards the anterior chamber, which is in front of the iris, and then it's going to be drained into the trabecular meshwork and the canal of Schlemm. So, also known as the uvascleral pathway. Anyway, if you have vasodilatation, you are going to constrict the outflow, okay? So constricting the outflow is a really bad thing. Why? Because basically no drainage, there will be more pressure inside of the eye. And why the pressure is bad? Because when there is more pressure inside of the eye, we are going to compress the optic nerve, which lead to blindness. So our job for a patient with a glaucoma is to decrease the pressure inside of the eye. By constricting the pupils, the drainage will become much better. Methacholine stimulates the muscarinic receptor in an airway when inhaled. Wait a second, that's not good. Yes, it's not good. Methacholine, when it stimulates the muscarinic receptor in the airway, it's going to lead to bronchoconstriction, and thus it's bad. The patient will start to suffocate. So we use it for diagnosing asthma, okay? How does this test work? Well, basically you bring the patient. You are like, do you have asthma? He's like, no, my breathing is okay. It's like a stress test. You make him inhale it, and then he has bronchoconstriction and cannot breathe anymore. So that's a positive sign. Pilocarpine contracts ciliary muscle of the eye, an open angle glaucoma. Yeah, so it's an open angle glaucoma. We also can use it. Why? Because it contracts the ciliary muscle of the eye, which normally produce the aqueous humorous. Also, it can lead to pupillary sphincter closure, and that is also useful for closed angle glaucoma. Open angle, closed angle glaucoma, do not stress about it too much. We'll speak about it in details when we discuss ophthalmology, which is a portion of CNS. They can cross the blood-brain barrier because they are a tertiary amine. Quaternary amine cannot cross, tertiary amine can cross. So it's a potent stimulator for sweat, tears, saliva, open angle, and closed angle glaucoma. Okay, so why? Because what is the significance of this drug? Well, why would I want somebody to sweat so much for me? Maybe if I want to do a sweat test, right? Who gets a sweat test? Who gets a sweat test? In which disease we need to check for sweat presence of chloride number in it? Well, I hope you are thinking about CF, cystic fibrosis. In this patient, you must make them sweat more often, and then check how much chloride is there in their sweat. So yeah, potent stimulator of the sweat, tears, and saliva, open angle and closed angle glaucoma, and also xerostomia. So we can use it for Sjogren disease in which the patient is really, really dry. Indirect agonist, as I said, we inhibit the acetylcholinesterase, thus we will have more acetylcholine because it will not be destroyed. So we have the anti-Alzheimer disease drug, which increases the acetylcholine, and one of the problems in Alzheimer disease was the decreased acetylcholine. Thus we decided to increase it. So donabizir, rivastigmine, and galantamine. So donariva, forget to dance on the gala. Yep, I actually use this mnemonic, it's kind of useful. So these drugs increase the acetylcholine in the synaptic cleft, which delay the Alzheimer symptoms. Make a note, it does not reverse Alzheimer, it does not treat Alzheimer, and it does not improve the mortality of the Alzheimer. Simply, the patient who have Alzheimer disease is going to live to 10-15 years after diagnosis, okay? Let's say 10 years. So you diagnose him today with 10 years, when he's going to lose his memory totally, maybe in 2 years. If you use it as a drug, he's going to lose totally his memory in 7 years. So you can see it just improves the symptoms, does not lead to full cure. Whew. Okay, Hydrophonium, really short-acting drug. It's historically used to diagnose myasthenia gravis. As I said, it's a really short-acting drug. It increases the acetylcholine. So if somebody has the myasthenia gravis, his symptoms are going to improve. But if he has something else, like some other problem, for example, too much acetylcholine, well, nothing will change. But if the patient has like symptoms of myasthenia gravis, and you give him Hydrophonium, his symptoms are going to become better, basically. So that is myasthenia gravis. So they're right. Replaced by anti-acetylcholine receptor antibodies, anti-acetylcholine receptor antibody test. So yeah, we don't do the Hydrophonium anymore, and we do the antibody test instead. Okay, Neostigmine. Neostigmine, more acetylcholine, and neo-CNS. So no CNS penetration due to positive charge. It's positively charged, it cannot go through the CNS. Keep in mind, pilocarpine can. Why? Because it's a tertiary amine, but quaternary amine cannot. So neostigmine, it's used as a post-operative and neurogenic ileus. So as I said, after you do surgery for someone, sometimes after the surgery they cannot poop or they cannot urinate. So you must use something with a cholinergic activity to make them poop and urinate, like neostigmine. So neurogenic ileus and urinary retention, myasthenia gravis as well, and they can lead to reversal of neuromuscular junction blockade post-operatively. Okay, so here is the thing. The patient, you anesthetize him, and after he woke up, he's like, doctor, I cannot go to the bathroom for some reason. You did something wrong. You did not do anything wrong. You just stimulated the parasympathetic, which means that, I'm sorry, you inhibited the parasympathetic by damaging it, basically, and that's why he's not pooping. It's going to revert himself, don't worry. But for this period of time, you need to make his GI work by giving him neostigmine. Pyridostigmine, it's a similar drug, also increases muscle strength, and it's used with glioburolate, hyoscyamine, and probanthylene to control the pyridostigmine side effect. Well, the pyridostigmine works at the nicotinic and the muscarinic receptor. We use it in myasthenia gravis. In myasthenia gravis, we only care about its nicotinic symptoms. The myasthenia gravis, I mean. We don't really care about the muscarinic symptoms. But when you give the pyridostigmine, they are stimulating the muscarinic receptor. So what you should do? Well, you should give a muscarinic antagonist like one of these guys, glycoburolate, hyoscyamine, or probanthylene, which is going to decrease the function on the muscarinic receptor and shunt all of the effect to the nicotinic receptor, which make you treat the myasthenia gravis. It can penetrate the CNS. Why? Because it's a quaternary. It does not penetrate the CNS. It does not. Why? Because it's a quaternary amine. Physiostigmine can penetrate the CNS, which means it can work as an antidote, and it can penetrate the CNS. He's a tertiary amine. More acetylcholine freely crosses the blood-brain barrier because it's a tertiary amine. It can be used as an antidote for atropine. Okay? So what about the poisons? Anticholinesterase poisoning, we have the following drugs. So mostly it's due to organophosphate, which are pesticide, okay? Also known like parathion, malathion, and all of these guys. They inhibit the acetylcholine esterase, which increase the acetylcholine, okay, in human beings. Also in insects. In insects is good because we kill them, but in a human being is bad because we kill ourselves. So organophosphates are commonly used in insecticides. Poisoning usually seen in farmers. So the patient is going to come to you and he will have dumbbells. It's going to be either a farmer or some terrorist attack. In Japan, I think in the early 2004, 5, something like this, there was a Japanese group, terrorist group, that attacked the metro station with this. I mean organophosphate. Okay, they had a new master and they wanted like to give human sacrifices for him by spreading organophosphate inside of the metro. So dumbbells, diarrhea, urination, meiosis, bronchospasm, bradycardia, emesis, lacrimation, sweating, and salivation. All of the parasympathetic stuff, basically. You can reverse it by atropine, which, it can cross the blood-brain barrier, relieving the CNS symptoms. However, it is only working at the muscarinic effect. What about the nicotinic effect? Well, he's not responsible for that. He cannot work on this. So they write, nicotinic effect, neuromuscular blockade, similar to succinylcholine. Succinylcholine is a depolarizing type of myorelaxant. So we really don't want to have this, you know. We don't want to have a case of blocking the nicotinic receptor, basically leading to paralysis of the patient. So you can reverse it by a drug called briladoxime, which basically regenerate the acetylcholine esterase, the enzyme that was inhibited, via dephosphorylation, but you must give it early because if it's not given early, the enzyme will undergo a procedure called aging, and if aging occur, the enzyme becomes totally useless. Briladoxime, it's a quaternary amine, which means does not cross the CNS. CNS effect like respiratory depression, lethargy, seizure, and coma can occur as well. Okay, so these are the anticholinesterase poisoning. They are super serious. Remember, the treatment is atropine and the briladoxime. The patient is going to have the dumbbell symptoms, which are all of the parasympathetic nervous system symptoms. Okay, good. So let me see. Okay, guys. So see you in 10 minutes. Hello guys, welcome back. So let's finish up the last thing we must speak about. We must speak about the muscarinic antagonist, atropine, and the sympathomimetics. So hopefully till here. So the muscarinic antagonist prototype is atropine. The idea of these, it's the exact opposite to what parasympathetic nervous system do. For example, parasympathetic nervous system lead to meiosis. These guys lead to mydriasis, like atropine, homoatropine, and the tropicamide. All of these can be used topically on the eye, and they lead to mydriasis and cycloplegia, which is like the lenses start changing the shape, which makes it dysfunctional. Benzotropine and trihexyphenidyl can be used in Parkinson's disease. Do not confuse the one that are used for Alzheimer's disease. So the Parkinson's disease drug include benzotropine and the trihexyphenidyl. They also can be used in acute dystonia after usage of antipsychotics. Clyburolite, you always see it all over the time in surgeries. Why? It works in the GI and in the respiratory tract, and when given parenterally, it reduces the airway secretion. So if you want to do intubation during surgery, the patient is going to have less secretion, which makes the intubation much more easy. Orally, they can reduce the drooling and the risk of peptic ulcer, but we mostly don't use them for that. We use them parenterally most of the time to reduce this airway secretion, and thus we can insert the intubation tube. Okay, hyoscyamine. Hyoscyamine and diacylcyclamine are an antispasmodic, so they work in the GI, and they can be used in irritable bowel syndrome. Ipratropium and tiotropium, both of these are respiratory, and they can be used for COPD and asthma. Remember that tiotropium has much longer duration of action than ipratropium. Yeah, so these ones, they also call them the so for example, if we speak about tiotropium, it's the LAMA, long-acting muscarinic antagonist. Okay, long-acting muscarinic antagonist. So these other ones, such as these are less famous. So sulfenacine, oxybutynin, flavoxate, and tolteridine, all of these reduce bladder spasm and urge of urinary incontinence. How come? Well, the parasympathetic nervous system normally lead to contraction of the bladder. So if we are using an antagonist, we will have relaxation of the bladder. So they make the bladder soft. Okay. Scopolamine, we use it for motion sickness, like when you ride a ship or something like that. They come in a form of a patch that you can put behind your ears. Okay, what about atropine? Muscarinic antagonist used to treat bradycardia or for ophthalmic application. Keep in mind, for the bradycardia, all of the bradyarrhythmias actually, it's possible to use atropine, even for for AV block. Okay, so the atropine can be utilized in the eye. It increases the pupil dilatation, and it can lead for cycloplasia. Why would you use it for the eye? Well, we would like to use it for the eye for ophthalmological examination, to do a fundoscopy, so you can take a look at the retina. For the airways, it can lead to bronchodilation and decreased secretion, which is really useful in case of intubation. For the stomach, decreased acid secretion, and the gut, less motility. And for the bladder, less urgency in cases of cystitis. A blockage of the muscarinic effect, which were the dumbbells, if you remember, and anticholinesterase. But it has zero nicotinic effect. Thus, in case of organophosphate poisoning, for the nicotinic effect, you must use a different drug called preludexine. Okay. So, okay. The adverse effects are these guys: hot as a hare, fast as a fiddle, dry as a bone, red as a beet, blind as a bat, mad as a hatter, full as a flask. So that is what? Hot as a hare is basically the high body temperature because low sweating. Remember, the sweating was mediated by acetylcholine. Yes, it was sympathetic, but it was mediated by acetylcholine. And fast as a fiddle, that is the high heart rate, okay? Dry as a bone, that is the dry skin and the dry mouth. Red as a beet, that is the flushed skin. And blind as a bat, that is the cycloplasia. And also they have constipation, and they are disorientation, which is mad as a hatter. Okay, so it can cause an acute angle closure glaucoma in elderly due to mydriasis. So they lead to mydriasis, which blocks the drainage of the eye, and thus we will have what? Glaucoma. Urinary retention in men with a benign prostatic hyperplasia, and hyperthermia in infants. Keep in mind that you can also get atropine poisoning not only from atropine, but also from the plant that give atropine, which is Atropina belladonna, and also from Jimson weed. Let me show you how Jimson weed looks like. Okay, so this is Jimson weed. And this is Atropa belladonna. Okay. So the next thing we are going to speak about are the direct sympathomimetics. So we have, first of all, albuterol, salmeterol, and terbutaline. All of these can function on the beta 2 and the beta 1 receptor. So mainly beta receptor. They are agonists, so they will increase the effect. They can increase the heart rate, but little effect. Why? Because the beta 2 effect is much higher than the beta 1 effect. Albuterol can be used for an acute asthma and COPD. Guys, can you hear me? Can you hear me, please? Okay, good. Because it just wrote me something unstable internet, I thought. Yeah. Anyway, so albuterol for an acute asthma or COPD because it leads to bronchodilation. Salmeterol, it can be for the long-term use for asthma and COPD. Terbutaline, it is for also the same deal, but most importantly, terbutaline for tocolysis, which is inhibition of the contraction of the delivery. So that will delay the delivery. Dobutamine drugs can work at the beta 1 more than the beta 2, but also can work at alpha. That means that they can be used, that they increase the cardiac output, obviously, because working at the beta 1 and the heart rate, but lower blood pressure. How come? Because they work at the beta 2, which leads to vasodilatation. So it can be used for cardiac stress testing. What is tocolysis? Tocolysis is stoppage of the contraction of labor. So when, let's say a lady is in a 28 week of a pregnancy, should she deliver? The answer is no. We normally deliver a baby at 40 weeks. So she start having contraction. How you can stop them? Give terbutaline. So it postponed the contraction in the lady. Okay. So tocolysis is delaying the contraction of a lady, establish the contraction of the lady. So we use the butamine for cardiogenic shock. That's the take home. It increases the anotropy. So wait a second. Cardiogenic shock. The drug of choice, dobutamine. Also you can use dopamine. What about anaphylactic shock? What's your drug for anaphylactic shock? Excellent, it's epinephrine. What about septic shock? Septic shock. Norepinephrine, absolutely correct. Good. So dopamine can work at the D1 receptor and the D2 receptor equally. So also it can work at the beta receptor and the alpha receptor. We used to use dopamine as a cardiogenic shock drug, but then it was not as good as dobutamine, so we stopped. So it increases the blood pressure if given in a high dose and increases the heart rate and cardiac output. This is good, and this is good for cardiogenic shock, but this is bad, so that's why we stopped to use it. While in dobutamine, cardiac output, heart failure, good. So dobutamine is much more better. So it can be used, the dopamine, for unstable bradycardia and shock as well, anotropy and chronotropic effect at a lower dosage via the beta effect. And the vasoconstriction at high dosage via the alpha effect. Let me explain what is anotropy. Anotropy means the contractility of the heart, while chronotropy is how fast it's going, so the heart rate. The next thing is epinephrine. Epinephrine, it's beta more than an alpha. It increases the blood pressure in high dosages and high heart rate, high cardiac output. We utilize it in asthma. Do we give it in asthma IV or intramuscularly? The epinephrine. IV or IM? IM, absolutely. IM. Yes, a quick administration, EpiPen, just shoot it in. Anaphylaxis, asthma, shock, and open-angle glaucoma. So, yeah, for all of these we can use it because also the alpha effect predominates at high dosages and it can reduce the amount of aqueous humorous production. Stronger effect at the beta 2 receptor than norepinephrine. Norepinephrine, where it is, it's here. You can see it does not have a beta 2 effect. So the next drug is phenoldobam. It's a D1 agonist. It leads to vasodilatation, which reduces the heart rate, which reduces the blood pressure, and leading to reflex tachycardia, okay, and higher cardiac output. Postoperative hypertension, hypertensive crisis, and also can lead to vasodilate. It can function as a vasodilator of the coronary, peripheral vessel, renal, and splenic vessels. It promotes natriuresis, which means more sodium is going to the urine, which is a good thing, especially in cases of heart failure. Because more sodium in the urine, more water in the urine, less volume in the blood, and that means less cardiac output and less work of the heart. It can cause hypotension, tachycardia, flushing, and headache. So the increase in the heart rate is a bad idea. You don't want the heart rate to increase in, coronary artery disease. But mostly the main idea of it is for the postoperative hypertension. So it reduces the blood pressure by vasodilatation. So it does the job, basically. Isobutyrenol works at beta 1 and beta 2 equally. So it will increase the heart rate, cardiac output. Its function on the beta 2 will lead to vasodilatation, which decreases the blood pressure. We can use it for checking for tachyarrhythmia. For example, you have a patient and this patient is like, you are like, we want to do a stress test on you. And he's like, doctor, I'm paralyzed. I cannot move. You're like, no problem. I will make a chemical stress test on you. So you give him isobutyrenol, which make his heart work harder, right? Without even moving. And thus you can check if he does have if he has any type of acute coronary syndrome or angina or something like that. So it can worsen the ischemia and it has negligible alpha effect, so it's not mentioned. Midodrine, it's an alpha-1 agonist. It increases the blood pressure because it's a vasoconstrictor. Alpha-1 is a GQ, which leads to contraction of the smooth muscles. Also, it decreases the heart rate, has a reflex and less cardiac output. So autonomic insufficiency, we can use this one, especially those guys who are like, oh, my autonomic nervous system is messed up and there is basically a problemo in my autonomic nervous system. When I sit down and stand up, I have this orthostatic hypotension. They can be sitting down, they stand up, and they just faint, right? So midodrine is good for autonomic insufficiency and postural hypotension. It might exacerbate the supine hypertension, however. Okay, I mean the drug, of course. Mirabegron, remember, it's a B3 agonist, which means that it works where? It works on the detrusor muscle. Detrusor muscle. So, okay, it will be useful for urinary urgency or incontinence or overactive bladder. Why? It's a sympathetic, so sympathetic will retain, right? So if you have an overactive bladder, mirabegron is going to inhibit the overactivity. Norepinephrine, it's an alpha-1 more than alpha-2 more than beta-1. So that will increase the blood pressure by stimulating the alpha-1. And it's going to lead to reflexive bradycardia from high blood pressure due to alpha-1 agonism outweighs the direct beta-1 chronotropic effect. So yeah, because of the alpha-1 is really, really potent in norepinephrine, it's going to lead to reflexive bradycardia regardless of the beta-1 activity. Keep in mind that we can use it for hypotension, most importantly septic shock. Again, septic shock, norepinephrine. Anaphylactic shock, epinephrine. Cardiogenic shock, dobutamine. Phenylephrine is working at the alpha-1 and much more than the alpha-2. It increases the blood pressure by vasoconstriction and decreases the heart rate and the cardiac output. It can lead to hypotension because it works as a vasoconstrictor. It can be used as in ocular procedures such as fundoscopy because it's a mydriasis. Mydriatic, sorry, makes the pupil larger, and rhinitis because it leads to decongestion. Keep in mind that if you keep using it recurrently, it will not work anymore, and we call that syndrome tachyphylaxis. Ischemic preapsium as well, and this one is scary, and I would share it with you. Basically, the patients who take like sildenafil, Viagra, and he takes a higher dosage than he should, he might sometimes, rarely, develop ischemic preapsium, in which the patient is having a huge amount of blood inside of his venous, and he's erected for 6 hours. This is abnormal, and so he's going to the venous is going to die. So how do you treat the venous? By doing this. So you must inject him with phenylephrine, which is going to lead to vasoconstriction, which is going to reduce the basically the vasodilatation inside of the venous, and that to prevent the venous tissue from dying from necrosis from the congestion. Okay, so yeah, in the preapsium, is it still breaking? Hello, can you hear me? Okay. Actually, we are almost done. Just I want to finish up this page. So if we are speaking about the, yes, absolutely. Regarding the ischemic preapsium, patient who consumes sildenafil, which is a phosphodiesterase inhibitor, will have a massive vasodilatation in their corpus cavernosum, which is a structure inside of the venous, which is going to lead to a lot of blood inside of it, and thus the patient is at risk of necrosis. To treat him, you must inject the venous directly with phenylephrine, which lead to massive vasoconstriction and reduce the chance of ischemia. Okay? But remember, the injection must be directly to the venous, not IV. Okay. So the next one, indirect sympathomimetic. So we have amphetamines. Remember, indirect general agonist. They used to inhibit the reuptake, and they also used to come in, use the VMAT to enter the vesicle and displace norepinephrine. So they inhibit the reuptake. They also release the stored catecholamines, and we can use amphetamines for ADHD. We prefer to use the synthetic drugs of amphetamines, not the actual amphetamines. Also, they can use for obesity because they reduce the hunger, and for narcolepsy. Cocaine, an indirect general agonist as well, it's a reuptake inhibitor, will lead to vasoconstriction, can be used as a local anesthetic. Be careful of giving it with a beta blocker because you will have an unopposed alpha effect. So if you have an alpha receptor, alpha 1, beta 1, and beta 2. Cocaine is going to increase catecholamines, which are going to function on all of these. So if you use beta blocker, the whole catecholamines are going to hit the alpha 1, which lead to hypertension. So caution with giving beta blockers if cocaine intoxication is suspected. Unopposed alpha 1 activation will increase the blood pressure, leading to coronary vasospasm, which can lead to an MI basically. Causes mydriasis in eyes with an intact sympathetic innervation. Used to confirm Horner syndrome. Yes, Horner syndrome is a syndrome happening in the eye, basically leading to meiosis of the eye, which is like small pupil, and it happens due to sympathetic pathway damage, which can happen because, for example, a Bankos tumor of the lung or others. So to check if the patient truly has sympathetic nerve disorder, you give cocaine. If his eyes do truly have mydriasis, that means he does not have any innervation problem. But if they don't, he does have innervation problem. Ephedrine is also a general agonist, but it's an indirect sympathetomimetic. Basically, it's a agonist, and it leads to release of a stored catecholamines. It can be used as a nasal decongestant locally. It's known as pseudoephedrine, and also it can lead to tachyphylaxis, which means if you keep using it for a long period of time, it will stop working. Also, urinary incontinence because it leads to urine retention, and hypotension because it can release a lot of catecholamines which will bind to the alpha-1 receptor, leading to vasoconstriction. So we explained plenty of material today. I mean, plenty. 1, 2, 3, 4, 5, 6, 7. 7 pages. A little bit more. So I think it's enough for today. I think tomorrow is off, so the day after tomorrow, hopefully we'll finish up pharmacology. It's basically not much left from pharmacology. We'll just have to finish up the autonomic, so it will be just this page, this page, this page, and this page. Then speak a little bit about toxicities, like 4 pages of toxicities. And then there is just tables. These tables are just every single drug in the book that you have to know. So it just will go through them really, really quick. And that's it for today. I will see you guys next time. Bye-bye.